Good afternoon, everyone. I'd like to say thank you for joining us today. Next slide, please. Some quick disclaimers. VDH is rapidly working to develop resources to address COVID-19. Guidance changes and all participants are encouraged to continue their own research. If you have a question, please enter it into the chat and we'll include a response in agency follow-up correspondence. Next slide, please. This session does count toward continuing education credits. A VNA approved 1 hour CNE and Carilions Clinic CME program designates this as 1 AMA PRA Category 1 credit. All speakers have no conflict of interest to disclose. Dr. Stevens reported no relevant relationships or affiliations with any entity producing, marketing, or reselling or distributing healthcare goods consumed by or used on patients. He is sub-investigator on medical trial studies. However, there is no relevant financial conflicts, and that is largely in the context of coordinating clinical care at VCU Health. Following this session, you will be emailed the didactic and evaluation link and instruction for receiving educational units. Next slide, please. Some tips. This tele-echo clinic didactic is used for educational purposes. By participating, you are consenting to being recorded. Recordings will be on the projectechobox.com, password protected. Clinicians unable to join the live can view the recording later, and materials will be shared with the Project Echo community. Please mute yourself when not speaking, use the chat function to ask questions, and please do not share any information that identifies or can be linked to a patient's identity. Next slide, please. Our facilitator today is Dr. Stephanie Greasy-Williams. Dr. Greasy-Williams is a board-certified pediatrician with experience in both emergency rooms and urgent cares, as well as 6 years in the CDC Center for Preparedness and Response. Dr. Greasy-Williams is currently working tirelessly with VDH to help the COVID-19 response. Our VDH consultants are Diane Woolard and Carol Jamerson. Diane Woolard is the former director of VDH Division of Surveillance and Investigation who came out of retirement to help VDH in the COVID-19 response. Carol Jamerson is a nurse epidemiologist with VDH's Healthcare-Associated Infections and Antimicrobial Resistance Program and is an infection preventionist with 25 years of experience and board certification in infection prevention and control. Our clinical consultant is Dr. Colin Wozencraft, trained in internal medicine palliative in Richmond, Virginia, before practicing and teaching nationally and internationally, with a focus on implementing palliative medicine in developing nations. He now lives again in Richmond, retired from clinical practice, but continues an interest in medical education, ethics, and economics. Our speaker today is Dr. Michael P. Stevens. Dr. Stevens is the Associate Professor of Internal Medicine and the Associate Chair, Division of Infection Diseases at VCU Health. He is the Director of Antimicrobial Stewardship Program and an Associate Hospital Epidemiologist and the Director of Travel and Tropical Medicine Clinic. Dr. Colin Wozencraft will also be a case presenter for today for clinical current countermeasures. With that, I'd like to turn over this presentation to Dr. Greasy-Williams.
Thank you, Hector. Can you hear me?
Yes, I can hear you.
Can you hear me? Perfect, thank you. So good afternoon, everyone. I'd like to start by briefly reviewing Virginia's case counts and our epidemic curve. Oh, previous slide, please. The information on both of these slides is available on the Virginia Department of Health homepage, and these slides are also interactive if you access them through the website. As of yesterday, Virginia has 40,249 total cases with 1,281 total deaths. And as you can see on this heat map, the areas that account for the most cases are Northern Virginia, the Richmond metro area, and Southeastern Virginia. Next slide, please. Our epidemic curve shows the number of cases by date of symptom onset, with the yellow line showing a 7-day moving average. As you can see, it seems like the cases have been stable over the past several days. However, it is important to note that individuals with illness that have occurred in the past 14 days may not be reported yet. So this data may not be accurate, at least for the past few days. Next slide, please. Today's clinic topic will cover myths in medication management. And rather than having a normal didactic lecture, Dr. Stevens is going to be presenting this information in a Q&A format. He has provided a list of common questions about medication management that he'll answer first, and then if time allows, we'll open it up to a further Q&A from our participants. This will be followed by a case presentation, which will be presented by Dr. Wozencraft on the therapeutic management of a 57-year-old male with a past medical history of well-controlled hypertension on lisinopril and normal renal function. And Dr. Wozencraft will present this, and then we will open it up for discussion to talk about how to manage this patient with some input from Dr. Stevens. Next slide, please. At this point, I'd like to welcome Dr. Stevens, and I am going to turn it over to Hector to ask the first few questions about medication management. I would like to let everyone know, as we talk through this information, if you have questions, please post them in the chat box. If we do not have time to answer your question during this live session, we will be answering the question after the session and sending out all of those answers to everybody through email. So Hector, I'll turn it over to you.
Well, thank you so much, and thank you for the update. Dr. Stevens, thank you again for being here today. And as stated, this didactic will take on a question and answer format in medication management and myths. So with that, next slide, please. So Dr. Stevens, what is remdesivir and when is it used?
All right, well, I appreciate the opportunity to be here today and to speak with the group. I'll try to make my comments practical, clinically useful for frontline providers and not go over a lot of information people may be familiar with, but try to keep it to the latest, greatest, and where we are right now. So what's remdesivir? Remdesivir is an antiviral medication that the world had some experience with from things like Ebola. It was repurposed in the context of the SARS-CoV-2 or COVID-19 pandemic. Has got potent in vitro activity and then in animal studies as well, and is being trialed or has been trialed with patients. And what's really quite helpful to discuss at this point in time is the fact that two landmark studies were published in the last week or so, one on May 22nd, one yesterday, which gives us some sense of the clinical effectiveness of remdesivir. So a couple of bullet points on the drug and how we're using it in the context of COVID-19. It really is for inpatient use. It's an intravenous medication, and it was trialed for either 5 days or 10 days. And what we know now is it seems like the people who benefit most from the drug are folks that have hypoxic respiratory failure, but don't have hypoxic respiratory failure requiring high flow nasal cannula, non-invasive ventilation, mechanical ventilation, or ECMO. And so the people who benefited most in this New England Journal of Medicine paper that was published on the 22nd, which I believe looked at approximately 1,055 patients. And they looked at these patients and they found a time to clinical recovery benefit in patients who receive remdesivir. So these people, on average, improved around 11 days versus 15 days. There was no overall mortality benefit in the population studied. So the best we could say is it does have a modest clinical improvement benefit. And the people who benefit the most are people who are on oxygen, but aren't requiring severe oxygen supplementation. And so that's what we know now. The other thing that came out yesterday was a open label phase 3 study that looked at people who received 5 versus 10 days of remdesivir. And really that study showed that 5 days was just as good as 10 days in terms of clinical outcomes. And those outcomes included time to recovery, overall mortality. The authors do note, based on post hoc subgroup analysis, that potentially you could not extrapolate this out to people on mechanical ventilation. So anybody who is giving remdesivir via the emergency use authorization from the FDA or in the inpatient setting is aware that you can give it for 5 days or up to 10 days, and 10 days for people on mechanical ventilation. And the assertions of the authors for that trial that was released yesterday are consistent with the EUA mechanism. However, it's sort of debatable based on the way they did the analysis And practically, some folks are just giving 5 days across the board, although that's not consistent with the guidance within the EUA. So hopefully that's useful to folks, and certainly this is a place where we could have questions. I'll leave it up to you, Hector.
I definitely think that's a point of interest moving forward. For the purpose of time, though, I think we'll go ahead and move on to the question of what is hydroxychloroquine and how does it compare and contrast with the use of remdesivir?
So I think this is super important, especially from the outpatient perspective. Hydroxychloroquine, folks have experience with it as an immunomodulator in the setting of rheumatologic diseases, some dermatologic diseases, or autoimmune diseases. In terms of antiviral activity, it's been looked at with a number of different viruses over the year, although it appears to have in vitro, or in a petri dish activity. It really hasn't borne out to have in vivo, or in human beings, activity. And we're sort of starting to get a signal that it's not going to be effective for the treatment of COVID-19. We won't really know that until 2 randomized controlled trials finish and we can analyze those data. That's coming. You can anticipate that in the next 6 to 8 weeks, we'll actually have probably a definitive answer on this question. But the cumulative observational data now suggests that hydroxychloroquine is not effective. And so a really large study, international registry observational study, came out in the last 2 weeks that was published in Lancet, that looked at over 96,000 patients, over 15,000 patients that received hydroxychloroquine, and a cohort of folks that did not. And that study showed no benefit, clinical benefit, and increased mortality in folks that received hydroxychloroquine alone or hydroxychloroquine plus azithromycin. And in that group, there was an increase in arrhythmias. And so that's important to consider. Other things I would mention there, people often wonder, well, why in a population that has COVID-19, largely the studies have looked at people who have been admitted with COVID-19, does hydroxychloroquine cause more potential arrhythmias? Some studies have upwards of 20% with significant QTC prolongation, as opposed to people in the outpatient setting that seem to do fine with it when it's being used for autoimmune processes. And there's things that have been forwarded about that. There's considerations around potential electrolyte abnormalities, maybe low-level myocarditis, and predisposition to QTC prolongation. But the bottom line is, especially in the outpatient setting, people should not be using hydroxychloroquine at this time, and certainly not that combo of hydroxychloroquine and azithromycin. There's data that suggests it could be harmful, and there's really no compelling data to suggest that it's beneficial at this point. So I'll throw that out there for now.
Okay. And are the use of OTC supplements such as vitamin C, D, zinc, and green tea effective?
And so there's been some excitement around zinc, and some people have even mechanistically suggested that the combination of zinc and hydroxychloroquine may be beneficial. I will say there's no data to suggest this is the case. And so at this point in time, unfortunately, there are really no data to suggest that any of these supplements are effective.
And should ACE inhibitors be continued in patients at risk for COVID-19 or with the disease?
This is another question that comes up not infrequently. The question of whether people who are on ACE inhibitors or ARBs should be continued based on a theoretical risk that these may predispose folks to developing or developing worse COVID-19. And this has to do with the fact that the virus uses the ACE2 receptor in respiratory mucosa to invade the respiratory cells, essentially. And these drugs upregulate that receptor, and there's some theoretical thought that this might be a bad thing. Now, what we know from several large observational studies is this does not appear to be the case. Multiple major organizations, cardiology organizations, have said, do not stop the drugs, continue the drugs. The benefits outweigh the potential risks. And although the population of folks with longstanding cardiovascular disease are at risk for worse outcomes when it comes to how they will do if they develop infection, that is an association with the underlying cardiovascular risk and not with the drugs being given. So these observational studies showed that was the case regardless of what type of drug you looked at in terms of cardiovascular medication. So at this time, you can continue them. That's the right thing to do.
All right. And is the administration of pneumonia or flu vaccine useful in any way?
So I would say this is valuable for folks in general, the way it is valuable for your patients when we're not considering COVID-19. And certainly things like pneumonia, Streptococcus pneumonia vaccines may help to reduce the severity of secondary infections if somebody becomes infected with COVID-19 and develops lower respiratory illness. Influenza vaccine, because the prevalence of influenza is low now, is not super useful, but as we enter into the fall, people should certainly get influenza vaccinated for multiple reasons. All of the typical reasons people should get influenza vaccinated, but also to reduce the challenge in differentiating what somebody's acute respiratory illness is due to.
And is the guidance to use NSAIDs, allergy medication, saline wash, and UV disinfection lights helpful for patients?
So this is a broad question. I would say symptomatic management is certainly reasonable to offer patients, especially in the outpatient setting. Now, I would say some people have said don't use ibuprofen. That was based on a single letter to the editor and some theoretical postulation that these types of drugs could be harmful to patients. That's really not the case. There's no data suggests that. Major organizations say you can use NSAIDs in the context of clinical care per usual, and that's what we recommend, here at VCU at this time. In terms of other things like UV disinfection lights, these things are not things people should use on themselves, for sure. If this is in the context of cleaning environmental surfaces, I would say avoid this because you can have secondary toxicity with these devices if they're not used optimally, and just wipe down surfaces with an EPA approved, cleaning agent. If you do that, that will kill the virus. So I would avoid any kind of UV sort of period unless it's in the context of cleaning rooms in a healthcare setting, but this is not directly applicable to patient care.
And where can I find the latest resources on investigational treatments and clinical trials?
So again, this is a very good question. And at this point in time, there are over 500 separate clinical trials that are ongoing nationally and internationally. And it's hard to find a single source that really you can look at to see everything that's going on and sort through it. People did look at this. There's a Lancet article in the last, I think, 4 weeks where folks actually created a sort of mechanism that it's a database that you can go in and look at this stuff. But from a pragmatic standpoint, from a frontline healthcare perspective, I would say you can look at two sources. One is the VDH site. If you go under healthcare professionals and you look at therapeutics, there's a link to CDC information, which helps you really look to see what ongoing clinical trials are focused on COVID-19. That's probably the best way to do it, or you can go to the CDC site directly. Now, what I will say, even more pragmatic, is you should be aware of where your patients have access, to health systems in the community. So let's say you have a patient population, where are they potentially going to be admitted if they develop hypoxic respiratory failure? It would be useful to know, especially if you have any kind of relationship with that hospital, what their local potential investigational treatment options are. And the way I'd probably explore this is they probably have local treatment guidelines. If you can get your hands on a copy of that, that's useful, especially if you're going to be at all involved with the decision-making process about what to give, or even if you just want to know when those patients are discharged from the hospital and may have potential, secondary side effects or things to watch for, what were they given? That's what I would do. I would reach out to your local hospitals to see what they're offering.
And what is convalescent plasma?
So convalescent plasma, in a nutshell, is antibodies from people who have recovered from COVID-19 being infused into somebody who has active infection. And it's a way to provide passive humoral immunity to somebody in the hope that that reduces the severity of their illness and so their illness doesn't progress. And this has been used, for different diseases in one form or another for over 100 years. And so it's got great biologic and virologic plausibility. The world data on this for COVID-19 is not robust at this time, but is rapidly accumulating. This seems relatively safe. It's got caveats that you have with any blood product in terms of the very, very, almost infinitesimally small risk for infection. Also with other types of things you have to watch with blood product administration, like transfusion associated acute lung injury and those sorts of things. But it appears safe and it may have a clinical benefit. We'll know when randomized controlled trial data becomes available.
And lastly, where can I find the latest information on vaccine development?
This is another great question. There is a lot of information out there, but it's hard to navigate in terms of what's of great value. And what I would say here is, the same deal. I would look for information from trusted sources, and I would go through CDC to sort of see what's latest and greatest on this. What I could say just in general is there are a lot of different companies looking at different potential vaccine candidates, utilizing different technologies and mechanisms of vaccine creation. Really, there's 3 or 4 that look promising because of the way because of the process via which these things have to be tested and then created. We're probably not going to see any kind of vaccine in the immediate future. And so those timelines you see that are pretty extended, that's probably realistic.
Thank you for the didactic, Dr. Stevens. We're now going to transition into the case presentation. And with that, I'm going to hand back the presentation to Dr. Greasy Williams.
Thank you, Hector. Can you hear me okay?
Yes, I can hear you.
And I actually think we've got a little over 10 minutes to pursue some more Q&A about Dr. Stevens' information before we move into the case presentation. So it looks like someone has a question. I know you mentioned, Dr. Stevens, that over-the-counter supplements have no evidence that they can help with COVID-19, but is there any benefit to recommending vitamin C, D, and zinc for general immune support?
So what I would say is, unfortunately, no. Certainly when you use these things at sort of hyper or very large doses, they can actually be associated with harm. These things have been looked at in many ways over time, and unfortunately, they've never panned out in terms of being helpful. So at this point, I'd say they really don't have any benefit. Now, is there some sort of placebo effect, or do they provide folks with just some comfort knowing that they're trying to do something? Maybe, but certainly the data doesn't suggest they're useful or medically effective.
Great, thank you. And I know there's been some information about COVID-19 and cytokine storm and whether or not elderberry may be contraindicated in this case. What do you have to say about elderberry and whether people who are already taking it need to stop taking it or vice versa?
So I will acknowledge my sort of limited knowledge about elderberry here for sure. This is the first time I've actually heard that question. So I just don't know the answer to that. What I would say is I've not seen anything that suggests that would promote cytokine storm over anything else. Certainly if somebody develops COVID-19, it's reasonable to stop taking that. When you see the cytokine storm, usually you're seeing it in the context of in the second week of illness. So people have a sort of more typical viral presentation with symptoms, and then around day 7, day 8, there's some sort of hyperinflammatory immune response, and that's that cytokine storm-like process. And so you're going to be able to identify these people relatively early. You're probably going to know they're sick with COVID-19 or a compatible illness. And if there's no compelling reason to continue the drug, it would seem reasonable to stop it until they recover. But again, I'm not an expert on elderberry.
Great, thank you. And I have a few questions for you as well, but I'd just like to encourage everyone else, if you do have more questions for Dr. Stevens, please continue to post them in the chat box. As I said, if we don't have a chance to answer them during this live session, we will still answer them after we finish. So you talked a little bit about remdesivir, and I know that there are some supply issues in terms of getting access to that drug. So I was interested in hearing what your healthcare system is doing in terms of identifying which patients will get that drug.
So I think this is a really important question, and it's one every sort of medical center across the country is struggling with a little bit. These new trials that were released in the New England Journal of Medicine over the past week or so have been helpful here. So we had some experience with this over the last 2 months since we were a remdesivir, 2 clinical trials of remdesivir were done here. So our group had some experience with it. We look at the population that probably is going to benefit the most from this. So these are folks that are hypoxic. When you look at the groups within that large trial that was released on the 22nd of May, the groups that benefited from this were folks that were on oxygen, but they weren't on high flow oxygen, non-invasive ventilation, were not mechanically ventilated, were not on ECMO, but they were also not people who weren't on oxygen yet. So there's a window that appears where the drug is most effective. And so we really prioritize those folks. It's hard to say whether it's going to be useful in folks that are presenting after 10 days of illness or not. And so that question is still outstanding, but we would target folks that are presenting earlier than later. And so within 10 days of developing symptoms, we're really not using comorbidities outside of the exclusion criteria from the company to stratify people for whether they should get the drug or not. We don't know that. So we don't know enough about the disease to say a whole population should be excluded. Although the company does say if they have significant hepatitis, not to give the drug at baseline, and if they have a creatinine clearance or EGFR less than 30, not to give it. That's a little bit debatable, the creatinine clearance recommendation, but in general, a lot of places have embraced that, and we're currently using that here at VCU Health as well.
Great. I imagine that's a question that a lot of healthcare systems are trying to address right now. And in talking about one of our other therapeutic options, if a patient is interested or clinician is interested in convalescent plasma, what are the steps one takes to access a source and give it? Can you speak a little bit about that?
Absolutely. This is something that hospitals, should, if they have not looked into it, which I imagine probably most health systems at this point have looked into it, they should look into it because they can, it's available via expanded access under a Mayo Clinic protocol. And so they have to, put the system in place to be able to offer it to patients, but they can do this locally. And so that is something health systems should be able to stand up, regardless of where the health system is. So that is something most people should be able to access. Now, what I will say is it's still, in theory, experimental. Although people can get it under expanded access, big organizations like the Infectious Disease Society of America is still recommending only using it under a clinical trial. And so it's not necessarily a panacea. We have to wait to see how effective it is. It does appear to be safe, but the global experience with it is pretty limited.
Thank you. And it looks like we have another question from the chat box. Is there any evidence that COVID-19 is a bacterium instead of a virus, given that it can be treated with aspirin and a coagulant, or that those at least help a little bit?
So I'll speak to this in two parts because I think you raise an important sort of secondary question, Dr. Greasy Williams. Hopefully that's okay. Um, uh,
Absolutely.
all right. So the first thing is it's a virus. We know that it's absolutely a virus. We've identified the virus. We identified this early. If there's a silver lining to the pandemic, it's sort of recognition of how quickly we can do that and share those data, internationally. So it's a virus, absolutely a virus. It's not a bacteria. It's not any other kind of microbe, if you will. We know that. The pathophysiology of the disease we're still learning about. And so it appears that there's really three separate processes that are affecting folks. There's the direct viral infection and the damage from that and the sequela of that. So for some folks, there's a hyperinflammatory response, and that was already brought up in the context of a cytokine storm-like process. This is not cytokine release syndrome, but it's a hyperinflammatory process that is abnormal, and it's happening in a subset of patients. It's hard to know who that's going to happen in. The third thing is some folks are having clotting issues, and it's not just venous clots, it's arterial clots. And so the pathophysiology of that's unknown at this time, and who's going to benefit from anticoagulation or things like aspirin. This stuff is outside my wheelhouse to some extent. I'll fully acknowledge that. But I think the pathophysiology of that we're beginning to understand, but we don't know it fully. And so is that a direct viral effect on the vasculature? We don't know, but that's an area of great interest, and it's certainly important for us to figure out, as we manage these patients.
Great, thank you very much. And I think with that, we are going to move into our case presentation. I would encourage you all to continue posting questions in the chat box so that we